Alrighty, good afternoon and welcome everyone to our monthly All In for Kansas Kids Strengthening Early Childhood in Kansas Systems Building webinar for October 18th, 2023. My name is Julia Gruss. I am a research project specialist at KU's Center for Public Partnerships and Research, and I will be your webinar facilitator for today. I am joined by my CPPR colleague, Erica Figueroa, who will be dropping all relevant webinar links into the chat, as well as keeping an eye on the chat for any of your questions and comments. Before we get started with our presenters, don't forget to sign up for our weekly e-newsletter on the All In for Kansas Kids website so you can stay up to date with all of our early childhood systems updates. You'll also be receiving some of those updates following our presentations this afternoon. So without further ado, I'd like to introduce those presenters. First, we'll have Neil Rowe of KU CPPR presenting on the Kansas Home Visiting Community Readiness Assessment. And then he will be followed by Holly Frye of KDHE, who will give us some universal home visiting expansion highlights. So Neil, the floor is yours.
Thanks, Julia. My name is Neil Rowe. Bear with me. I am getting over a cold that my children have given me, but I will do my best to squeak through this presentation. And if you can't understand what I'm saying, you can ask for clarification in the chat. As Julia said, my name is Neil Rowe. I am an associate researcher senior at the University of Kansas Center for Public Partnerships and Research, and I'm excited to share with you today about the Kansas Home Visiting Community Readiness Assessment. I am going to start with my story and why home visiting is important to me and how I got connected with uh, home visiting. And so you can see here lots of pictures of me and my family, and I'll kind of point out things as I go through my story. So 13 years ago, I applied to graduate school at Iowa State University after working in residential wilderness therapy and adventure education. And it's because I applied to grad school because I wanted to know why the kids I worked with experienced trauma. And at the same time that I was applying for graduate school, the Maternal, Infant, and Early Childhood Home Visiting, MCV, program was created by the passing of the Patient Protection and Affordable Care Act. And one of the priorities of the MCV program was preventing and reducing childhood trauma, child maltreatment. Um, and while I did get into graduate school, and while I was in graduate school, the research assistantship program or research assistantship that I was given was evaluating the maternal, infant, and early childhood home visiting program in Iowa. And so I was supported by McV funding as a research assistant, and uh, and I was tasked, amongst other graduate assistants, with evaluating the use of MCV funding to support and expand home visiting in the state of Iowa for evidence-based programs. And as part of this task, I did observational analysis of home visits, and I also went out to families served by McV in Iowa. I went out to families' homes and did developmental assessments. I observed parent-child interactions and helped parents fill out some surveys about their parenting stress and knowledge of parenting practices, those kinds of things. On my time on the project, and I worked my way up the hierarchy of the research team to research project manager. And during that time, which was several years, 4 or 5 years on that project, I observed over 100 home visits and visited over 50 families throughout the state. And I saw firsthand the importance of this kind of family support and the need for it. And also, while in grad school, and I'll point to that top left-hand corner there, I became a dad. And there I am with my oldest daughter, Isley, uh, right when opening day happened in 2015. Uh, and we didn't win the World Series that year, but we did the next year. Uh, and so we were super excited for baseball season. She watched with me. Um, so I became a dad while in grad school, and this evaluation of home visiting and the need for family support and the need for home visiting became a lot more personal for me. We were now a family of three and trying to figure out a new life, and I had a ton of information and education on child development. That was my early childhood development was my specialty in graduate school, and none of that could have prepared me for being a father and not sleeping. And now you've got this little human to keep alive, nurture, and give the support and opportunities to have the most successful life. And so I wasn't prepared for that. And also I was trying to figure out how to make ends meet on $16,000 of a graduate assistance. Uh, as a graduate assistant, it was part-time, but I was a full-time student as well. And that was really hard. And all of a sudden I had to navigate all these social support systems, Medicaid, food stamps that I hadn't before, and and the communication lines for those things are from my experience really terrible. And if you need to figure something out, you get like a notice in the mail like, oh, you didn't provide this information. You will lose this support if you don't do this in this time period. And then you call and then you can't get a hold of anybody and you leave a message and no one ever calls you back. And so you have this stress like, oh, I'm gonna lose this thing. And if I lose this thing, how am I gonna make ends meet? And so I was in this situation where I was experiencing what some of these families that I visited experienced, and some of the families that I observed in home visits were in some of these same situations. So it became more real. It already was real because I saw it, I heard from families, but now it was personal for me because I experienced it. And I should also mention it was super lonely and exhausting being a parent, a new parent, and trying to play all of these different roles myself and figure things out. Uh, we were more than 3 hours from any family. I was finishing up a master's thesis, and so it was difficult. Uh, and as I and the master's thesis wasn't the end of it because I was getting a PhD in human development and in family studies. And like I said earlier, just that didn't prepare me for all the things that would be thrown at me in this time period. So as my work became more personal, as I observed uh, home visits with this new lens of being a father, uh, I decided to do my dissertation, specifically examining father presence, availability, and engagement, and their inclusion in activities by the home visitor. Because I was already doing observational analysis, and the observational analysis that we were currently doing didn't have a way of differentiating the parents or the caregivers. And so I decided to look at this because I started had to think I noticed that fathers, when they were there, weren't included in activities as much as the mothers were. And but I didn't have any way to demonstrate that with evidence. And so I adapted our observational measures so that I could do that and did my dissertation on it. And I should say I passed. I made it through that phase of life, and right out of grad school, I had a second child and got a job with the University of Kansas Center for Public Partnerships and Research. Uh, and specifically, my role there was going to be to support uh, home visiting efforts in Iowa, as well as some other McV supported work in Iowa. And over the last 5 years, I've been here 5 years, I've supported home visiting efforts and McV efforts in Kansas, in Iowa, and some nationwide efforts as well. And so just wanted to start off by saying that this work means a ton to me, and it is deeply tied to who I am. I don't just have experience doing it. Also, to tie back into my original why for going to graduate school, I want to say that home visiting provides direct support to families, linkages to other community resources and support, and it can prevent trauma, build resilience, and even through prenatal visits, prevent intergenerational transmission of trauma during pregnancy. So the power of home visits is real. Um, it also provides a return on investment between $1.80 to $5.70 for every dollar spent, including specifically reduced costs on child protection, K through 12 uh, educational intervention, costs on criminal justice and healthcare. Uh, it's also shown its significant effects on maternal outcomes, child brain development, and parent behavior and skills. So that is my why. I know the support provided from home visiting and the connections home visitors can help families make within their communities can help us build better futures where every Kansas child and their families can thrive. All right. I'm working off of two different slides. We've got the slides that are being shown on screen, and then I've got my own slides with notes. Okay, I'm going to talk about the story of the community readiness assessment. Uh, so why did we do this community readiness assessment? Well, we were ready to expand McV in Kansas in a few counties. That expansion was delayed due to the COVID-19 pandemic, and the expansion was rooted in some data from our 2020 uh, Kansas home visiting needs assessment that was it was required with the McV authorization, the prior McV authorization. So I should mention McV was recently reauthorized in 2022. That prior authorization to that required a needs assessment, and based on that needs assessment, we were going to expand McV in a few counties. That came to a halt because of the COVID-19 pandemic. And then in the time was now spring of 2022, we were ready to expand. And specifically HRSA, which funds McV, recommended a community readiness assessment. And two, when I had looked at the data that we were using to determine expansion counties, uh, I noticed that the data was really outdated. It was from 2012 to 2017. And here we were in 2022, and we were potentially going to use data as old as 2012 and as recent as 2017, 5 years prior to that, to make decisions. And so I thought, okay, well, this community readiness assessment is an opportunity for us to re-examine what our high need counties are, as well as to uh, to look at follow this community readiness process to see assess readiness in potential communities for MCV expansion. Julie, I'm just assuming you're moving on to the next slide because my presenter view for PowerPoint automatically throws another slide over where I had been looking at your view. Okay, good. I see we're at all in for Kansas Kids strategic plan. Also, we've got this great all in for Kansas Kids strategic plan. And strategy 5.2 is an increased capacity and equitable access to early childhood care and education programs and services through policy and administration directives. And tactic 5.2.6 for this is develop recommendations to expand promising and evidence-based home visiting models and support a statewide home visiting infrastructure with a variety of sustainable home visiting service options that meet the needs of families and communities. Okay, well, we're going to do the statewide community readiness assessment, and we're going to re-examine our high need counties so we have more recent data to base decisions for MCV expansion. But if we're already going to collect statewide data, man, it would be great to collect some data also that could help us uh, in uh, in building a statewide infrastructure for home visiting and support expansion for home visiting statewide. That's a tactic in our All In for Kansas Kids strategic plan. Things seem to be coming together at the right time due to this delay in the COVID-19, due to the COVID-19 pandemic, uh, for this opportunity to use this community readiness assessment for multiple purposes. Okay, so next we're going to talk about what was included in the assessment. And when I say assessment here, I want to say I'm going to talk about the high need assessment. So assessing which communities were highest need and should be highest priority for expansion of MCV specifically. All right. Since we had outdated data that determined our highest need communities that we gathered uh, for the 2020 MCV needs home visiting needs assessment, we gathered state level data that we had from the last 3 years, 2019 to 2021, and we included vital statistics birth risk data because this detailed the concentration of need for the target population for home visiting. So we used 3-year vital statistics birth risk data, um, as well as some other statewide data that fit in with the requirements for the MCV program. So specifically, when I say birth risk, these included registered for Medicaid or WIC, unmarried, less than high school education, less than 20 years old, smoked during or before pregnancy, low birth weight or preterm birth, and less than adequate prenatal care or no care in the first trimester. And we considered uh, the percentage of births with 2+ of those risks or 3+ of those risks. So it's looking quite literally at the concentration of risk for the births across 3 years in each of our counties. And then in addition to that, we looked at 2019, uh, the 2021 state level data for the following need domains. And these need domains were determined because of McVean is funding is required to be used in communities with concentrations of these specific need domains. So we had social economic status with indicators of poverty level, high school dropout, high school non-graduation, unemployment, adverse perinatal outcomes, including preterm birth, low birth weight, inadequate prenatal care, and did not initiate breastfeeding, uh, substance use, which included opioid prescription rates for the county, as well as maternal smoking, uh, crime rate, or crime as a domain with crime rate and juvenile crime rate as indicators, domestic violence, which is just the incident rate of domestic violence, and the substantiated maltreatment rate for child maltreatment. Next, I'm going to show you a heat map of 2+ risk, showing the concentration of 2+ risk for births 2019 to 2021. And so you can see we've got Wyandotte County at 67% of births have 2+ risk. We've got an area of Kansas, southeast Kansas, that has a concentration of 2+ birth risk, and then another area of Kansas in southwest Kansas that has a concentration of 2+ birth risks as well. Next, we're going to look at 3+ birth risks. I should note that the black or dark gray on this map indicates where there were less than 10 births with 3+ birth risk, and so that data was suppressed, and so we're not showing the concentration there. As a region, not just visually here, but as a KDHE vital statistics region, we've got southeast Kansas and southwest Kansas that had significantly higher concentrations of birth risk than north central and south central Kansas and northeast and northwest Kansas. So southeast and southwest Kansas had a concentration of 3+ birth risk of 32 and 33%. North central and south central had both had 24% for concentration of 3+ birth risks, and then northeast and northwest regions had 19 and 17%. Again, you can see Wyandotte County shows up. We've got several counties in southwest Kansas that have the highest concentration, and you'll also notice Cowley County, Montgomery County, Woodson County, and in general higher concentrations in southeast and southwest Kansas. And here is a map of our high need domains. And so I outlined what those were before. We had 6 high need domains. And here, this identifies the number of those domains that were at or above our cutoff point that would identify that domain as a high need domain for that county. And so you can see in Southeast Kansas, we've got several counties that were identified as high need for every single one of those domains. Allen, Labette, Montgomery, Holly had 5. Wyandotte also had 5. We also examined reach of our need-based home visiting programs. And so we gathered community level family served data from need-based home visiting providers statewide. This is, when I say gathered, I do mean that the number of families, let me backtrack. We examined reach based on the number of families estimated to be in need of home visiting. So that is the denominator. And we looked at that a couple different ways. We looked at that in terms of the number of families in a particular county who are below poverty level. So that could be potentially the number of families in need of home visiting. But we also looked at it in terms of the number of families who were at 3+ birth risk across 4 years of data. And so that's our denominator. And then we had the number of families served in a county. Gathering the number of families served by need-based home visiting by county was a challenging task because not all home visiting programs use the same data system. This wasn't as easy as just doing an export on a data system. We for a lot of this data, we had to ask programs either directly at the local level or ask state administrators of home visiting for home visiting models to ask that information from the local level. And so it was very challenging. And I should also mention that some programs don't maintain families served data based on county residents and don't have access to that data. So while we do have some state administrators that have access to data, they may not have access to the local data system that houses where families reside who are being served. And so in some of these cases where we couldn't get exact families served who live in this county, we were able to provide estimates. In some cases, we provided estimates based on slots that were allocated for a particular county. And for another, we estimated based on county populations for the geographic area that uh, that they were able to provide families served by. And so while I think this is the most comprehensive family served, community level family served data that we have had in the past, it's not exact because of those limitations that I just mentioned. That said, to ensure McPhee funding goes to the highest need areas with the lowest reach, we needed a way for for to be able to do this. So that's how we did it. And Sorry, I lost my spot. Um, okay, I think we can move on to our next piece here. So this heat map shows our need-based home visiting reach and the areas in with kind of the more reddish hue have less reach. So some of those have uh, 0%. So no families served by need-based home visiting programs. Uh, and then we've also got some that are really low relative to uh, our population of families in need of home visiting. And again, for this map, it's the number of families with 3+ birth risks across 2018 to 2021 based on vital statistics data. I should mention that you can see Wyandotte County, 21% reach. Allen County also at that 21% reach. You'll remember Cowley County came up in our previous maps, 10% reach. And then you've got a big uh, uh, area in southwest Kansas, which as a region, uh, we had uh, concentration of high concentration of birth risk, um, and looked like we have relatively low reach for need-based home thing. And then South Central Kansas, there's quite a few counties where we have low reach as well. Um, I should note that our highest need communities, which I pointed out, Wyandotte, Allen County, and Cowley County, were also underserved relative to their neighboring high need communities. And so I don't know if you remember from the need-based domains, Labette, uh, Montgomery, Woodson were had I think six domains that were uh, above the cutoff, but the reach there is way higher than Cowley, Wyandotte, and uh, and Allen, and so that's how we arrived at these communities we would recommend for McPhee expansion. All right, let's move on. So that is the high need assessment that we did that helped us arrive on our recommendations for McVie expansion. In addition to all of that examination that we did, we also sent out a home visitor, supervisor, and administrator survey to home visiting programs statewide, and we got over 500 responses. We sent out a survey to expecting families and families with children 5 and under. Got over 500 responses statewide for that. And we used this information from those responses to assess readiness for expansion for our recommended communities in Allen, Cowley, and Wyandotte. And we can hopefully use this information at the aggregate state level uh, to support, like I said in at the beginning, building a statewide infrastructure for home visiting and support expansion of home visiting statewide. There's a whole lot that we included in those surveys that we didn't necessarily need for the McVie to determine McVie counties, but we included it there because we saw the opportunity. And so we asked home visitors and supervisors about turnover and retention and well-being, and uh, we asked families about whether they had heard of home visiting before, and if they'd heard of home visiting before, if they'd had home visiting, and if they hadn't heard of home visiting, we asked them uh, what what kind of home visiting they would be interested in. And so we have just ripe data to use to support uh, a statewide infrastructure. Uh, we haven't had this expansive data surrounding this topic, home visiting, from sources who affect and are affected by the programs before. And so my hope is that we can use that. I've taken a lot of time to go over the high need assessment, and maybe there'll be another opportunity where I can kind of share some of our survey data as well. But I do want to stop there. I know some people did have some questions, and we also have Holly, who's going to present on universal home visiting expansion.
Well, there is a question in the chat that was asking why only maternal smoking, why not the caregiver smoking?
That's what's in vital statistics data. That's what's collected.
Yeah, that's what's
You
collected.
can take that up with the epi.
That up with the epi.
Epidemiologist. That's what I'm. I'll try not to use technical lingo.
If anybody else has any questions, you can drop them in the chat. Otherwise, we will be moving on to Holly. All right.
Does my sound okay?
Yep, you are good,
Just a
Holly.
tidbit. I think this leads into universal home visiting. That when we like I said, we surveyed families if they'd heard of home visiting, and if they hadn't heard of home visiting, we asked if they would be interested in home visiting. Approximately, I want to make sure I get this data correct. I can't find it. The short of it is when families who are interested in home visiting, I ask them really specifically the type of home visiting that they would be interested in. And I described our universal home visiting program, a brief, like one time, one or a few times before before birth, during pregnancy, and one to a few times after giving birth, all the way up to like short-term weekly home visits for 2 to 3 months to long-term multiple year involvement in home visiting, anywhere from monthly to weekly visits. And by far, the largest percentage of interest was in that first column. And I think that points to universal home visiting as being this doorway into our broader continuum of home visiting options in our state, because it's what families are most interested in when they don't know anything about it. So I'll use that to lead into Holly's presentation.
All right, thanks, Neil. Well, I'm Holly Frye, and I am the Maternal and Child Health Program Consultant at Kansas Department of Health and Environment. And Neil, I really appreciated your why and think that's a great testament to the benefits of home visiting. And I didn't prepare a very eloquent why for my presentation, but as a child, my family did receive home visiting services, and I would love to have that for all the families in Kansas. And so that is part of my why. So I'm going to talk about universal home visiting. And before we start, I thought I would just capture what universal is, and Neil kind of just described it. It's home visiting that everyone is eligible for. Every family where a person is pregnant, all the way up through their child's first birthday. And the purpose is to provide 1 or 2 home visits prenatally and 1 or 2 visits postpartum, to assess the family's needs and strengths and connect to services as needed. And then also provide just kind of a baseline education of what you need to know when you're pregnant and when you're starting to raise children. And part of that assessment and referring on to other services can be to those longer term, more intensive, need-based home visiting programs that Neil talked about. So in state fiscal year 2023, which ran from July 1, 2022 to June 30th, 2023, the Kansas Department of Health and Environment, Bureau of Family Health, was awarded more Children's Initiative funds to expand universal home visiting. And in that first year, we launched a request for applications for current maternal and child health programs across the state to apply for additional home visiting funds to expand in their communities. And so we had 16 apply and be awarded, and they provided home visiting, universal home visiting services starting October 1 in the expanded capacity, all the way through today as we just began state fiscal year July 1 in this year, 2023. So I want to share some progress about what's been achieved as a result of that expansion. And so in year 1 that ran from October 1, 2022 to June 30, 2023, we were able to expand reach of universal home visiting into Lyon County through CareArc, which is the federally qualified health center there that also operates as a health department, and as well as McPherson County, which is being served by Saline County Health Department. Okay, just getting some additional notes up. Then we also expanded capacity to reach more clients in Sedgwick County. And what I mean by that is Sedgwick County Health Department had been providing universal home visiting, but with this expansion, we were also able to start that service at the University of Kansas in Wichita, which also has other maternal and child health programming. They're able to cross-refer between those programs into universal home visiting and vice versa, as well as into Cherokee, Labette, Bourbon, and Crawford counties through the Community Health Center of Southeast Kansas. All right, I think we're ready for year 2 progress. So in year 2, which just started July 1, a couple months ago, we expanded geographically into Phillips County, Sheridan County, and Finney County through the health departments, which was really exciting, particularly like in Finney County. They are an area with an OB provider shortage. And then in Phillips and Sheridan counties in Northwest Kansas, where, at least as far as the maternal and child health program, we hadn't had as much reach in the past. So then on the next slide, I demonstrate where in the state is a maternal and child health program that has been working on universal home visiting, and then those areas where it's expanded as a result of additional funding. And you can see that with the represented by a pink star. So I think like one benefit of universal home visiting, kind of like Neil was talking about, it's shorter term, which might be more palatable to families who are a little unsure about committing to a longer term program. And in those areas where needs-based programs don't exist, the universal home visiting program can provide additional services beyond the 1 or 2 visits prenatally and postpartum. If the need is there, there's the flexibility to provide support to the family in a more intense manner or longer term. And I also wanted to touch on new referral connections made, because part of being effective with home visiting programs is being able to connect the family to the program. Is that access piece. Our programs aren't going to be beneficial if people aren't getting to them. And part of that is partnerships and making connections with other organizations in the community. So I want to highlight new connections made as a result of universal home visiting expansion. And for example, you can see the different sites on this slide and the partnerships made. There's a lot of effort to get referrals from birthing centers or hospitals where families are going for prenatal care and delivering, and making that connection between the care that they get in the facility when they deliver baby and then postpartum when they go home and need support with the new little family member. And then I'll go to the next slide and share some examples of family successes and outcomes. We ask our universal home visiting programs to provide this to us every 6 months. And so one example from the University of Kansas, which was a site that started universal home visiting as a result of this expansion opportunity, wrote from one of their clients who said that they wish the program was around when they had their first baby. And it's really nice to be able to learn the information and find out the resources that are around Wichita, and they really appreciated the program. I mean, I hear a lot of similarities from what Neil shared with his family experience. And then an enrollment of a new mother, again, through the University of Kansas Wichita program, who had no support system. And she stated that the expansion project helped her to find the resources she needs for baby. Her home visitor assisted with filling out a DCF application for food stamps. I think we call that SNAP, but or another name for food stamps is SNAP, and helped her to enroll in WIC and Baby Talk, which is their group-based prenatal education class. And the new mother stated that she really appreciates the support and feels like she has someone to help her. And then I have a couple other examples. We're down to 8 minutes though, so maybe I will wait and see if there are questions. And also, thank you. I did want to share. So next steps are wider promotion of the funding opportunity for universal home visiting. Again, trying to increase those referral sources from community partners and working with other state initiatives to improve maternal mortality and infant mortality and health outcomes. And then increased regional service delivery. And so looking at, for those counties where services don't exist or not as robustly as they could be to fulfill all the need, where can we have those counties partner with others that are offering programs to expand from that organization into neighboring counties? And then working with currently the Center for Public Partnerships and Research and Neil to evaluate this expansion and create profiles for the sites that participated in expansion in the first year. I think that's all I had.
Yes. Do we have any questions for Holly? All right, I'm not seeing anything in the chat. So Holly, I think that that's good. Alrighty, I just want to thank Holly and Neil for both of their robust presentations on home visiting in Kansas and sharing their stories with us today. And I am going to move on to our early childhood systems updates. All right, a funding opportunity through the Children's Cabinet with the Capital Projects Fund Accelerator. The CPF will fund construction-only efforts to build multi-purpose facilities and has unique requirements that must be met to be eligible due to very direct and specific guidelines from the federal funder, who is the U.S. Treasury. So due to these very specific guidelines, the Children's Cabinet Accelerator staff are going to be hosting an informational webinar this Friday, October 20th at noon. Where they will review the criteria outlined in the request for proposal and take your questions. The registration link will be dropped in the chat by Erica, and the recording for this meeting will also be posted to the All In website by next Tuesday, October 24th. The first round of this funding has closed, and the second round won't close until December 18th. So get your information now in order to build a strong application for round 2. Engaging with experts at the Family Voice Roundtable sessions. KDHE's family leadership team is looking for parents and primary caregivers of children birth through age 5 to participate in one of these scheduled sessions to help identify childcare topics that are important to you. These insights will assist in providing resources that will be easily accessible to all Kansas families, and all Family Voice Roundtable participants will receive a stipend of $75 for their time, commitment, and active participation. If you are interested, please register for one of the following sessions. Saturday, November 4th will be offered in English and Spanish, and Monday, November 6th, offered in English. There's only space for 50 participants per session, so register today, and that link will also be placed in the chat for you as well. Our Kansas Shared Services Network, Child Care Aware of Kansas has established a shared services network for licensed Kansas child care programs. This means more supports and lower costs for providers, starting with child care management systems. So the foundation of most shared service networks is child care management software, which can help providers communicate with families and staff, set up reminders, handle scheduling and calendars, manage billing, reporting, and enrollment, and much more. So Child Care Aware of Kansas has partnered with Bright Wheel and Playground to offer this software to KDHE licensed providers at no cost to them. So you can learn more about both of these partners and compare in the link that Erica will be putting in the chat. And you can also reach out to a shared services consultant from Childcare Aware by sending an email to info@ks.childcareaware.org. Next is the Kansas Parents as Teachers Association. They have started another monthly training series back in July. This training series is for teachers and educators, and all sessions are free to current Kansas Parents as Teacher Association members. If you're interested in becoming a member, you can find the link in the chat to register. Tomorrow's session is from 1 to 2:30 and is on perinatal mental health. Each month thereafter will feature a topic relevant to early childhood and family issues. Don't miss out on these opportunities for some further professional development. More professional development in the form of upcoming conferences. Kansas 2023 Breastfeeding Conference will be located at the Drury Plaza Hotel Broadview in Wichita from October 26th through the 27th. Day one of this conference will focus on hot topics in lactation to provide clinical skills and breastfeeding knowledge for healthcare professionals and others who serve families. And day two will focus on the policies and systems needed to successfully create communities supporting breastfeeding. Online registration for this conference closes this Friday, October 20th at 5 p.m. So register before it's too late. Again, that link will be placed into the chat for you for easy access. And then the National Association for the Education of Young Children is hosting their annual conference in Nashville, Tennessee, from November 15th through the 18th. Gathering early childhood educators from around the globe to connect, collaborate, and learn together. You can learn more about this year's conference and register by following the link in the chat. Upcoming meetings, reminders, and next steps. There is a special Children's Cabinet meeting that will be held tomorrow, Thursday, October 19th from 11:30 to 1:30 p.m. And the purpose of this meeting is to review and approve the round one funding of the Capital Projects Fund Accelerator grants. This will be live streamed on YouTube, on the Children's Cabinet YouTube channel, as well as the Early Childhood Recommendations Panel meeting that will be hosted this Friday, October 20th from 9 to 11:30 a.m., also live streamed on the Children's Cabinet YouTube channel. And our next early childhood systems building webinar will be on Wednesday, November 15th. Thank you so much, everyone, for joining us today. As always, please stay up to date with us by signing up for our e-newsletter, following us on Twitter or begrudgingly X, and subscribing to our YouTube channel where you can watch recordings or the live streams of most of our meetings. So again, thank you so much for joining us on this Wednesday, and we hope to see you next month.